Green Book of Guideline. That book has also pediatric poisoning, okay, emergency accident and poisoning. So let us start with this accident and poisoning chapter 7, which we did not cover in our last class. Now we will cover this one. So this screen is audible to you now, everyone? Can anyone unmute the mic?
Yes, now
Yes,
it's
ma'am.
audible
Yes,
to me.
miss.
Okay, so everyone joined? I think everyone joined. So let us start. Okay, so chapter 7, accident and poisoning. So from this book, what is our main reading? We will know that how the poisoning question came. Number one, accident and poisoning question. Not only poisoning, here this chapter is actually accident and emergency. Okay, so how the poisoning question came main. Who can tell us that which poisoning is main that comes in our exam in UK MRCPCH exam? Which
Paracetamol.
poisoning? Paracetamol, very good. Yes, paracetamol poisoning is the most common because it is the most common over-the-counter drug. Okay, that's why it used in every home for pain relief, for anti-inflammatory actions. So most of the home has this one, and as we know from our last class that paracetamol poisoning is very common in young children, because in young children they have only sulfation method of metabolizing paracetamol. They do not have glucuronidation pathway that is not active because of the immature liver. Okay, so from this we have to know that why the young children are affected with poisoning more. So this is the physiology. Okay, just read this one, that young children have less fat, more elastic skeleton, okay, and the larger body surface area. Question comes from this, okay, that which drug needs more doses of children in children, like gentamicin. It is a water soluble drug. Okay, so it needs more doses. If you see, the small children needs more gentamicin dose than the large children, than the big children. Okay, so this kind of question, like pathophysiology question, will come in your TAS. And pharmacology basically is a TAS exam question, but yes, FOP, it can come like some drugs, that is ADHD drug, methylphenidate, atomoxetine. These drugs are related with clinical scenario in FOP cases book. That pharmacology can come in your FOP exam. Okay, so don't be surprised if you see pharmacology question in FOP. Okay, so TAS and FOP, for both exam, pharmacology is very important, even for AKP. Okay, AKP part 2 exam, MRCPCH, that also contains some pharmacology. Okay, so this important things like larger body surface area, their blood pressure is often not so much maintained well. Okay, so these things contribute accident and poisoning. Okay, so read these few lines from this page. Next, from this page, what we will read, that um, primary and secondary injury. These examples of primary and secondary injury. That when some poisoning or accident occur in children, the primary effect may cause damage. Even damage can occur by secondary effect. What is secondary effect? Suppose there was extradural hemorrhage, and in that extradural hemorrhage, um, there can be secondary effect like cerebral edema. Subdural hemorrhage, there can be secondary effect like infection. Okay, subarachnoid hemorrhage can cause hypoxia. Okay, so these are the secondary effect that will cause after the primary injury, and both are dangerous. Primary effect and secondary effect, both are dangerous. Okay, can anyone tell me which one is more dangerous, extradural hemorrhage and subdural hemorrhage? Which has the highest death and uh, you have heard the name of lucid interval? Who can tell us that what is lucid interval? What is this thing? In which area, in which hemorrhage the patient die early or suddenly they die? Can anyone? Open mics, please. We want a active discussion.
Extradural is more dangerous, I guess.
Extradural mode.
Extradural, yeah.
Yes. Why? Can you tell us why?
Sudden death can occur after this.
Yes. Yeah, I am telling you a little bit more.
Okay.
Suppose extradural hemorrhage, they have durameter. This is I'm trying to draw, okay? I'm trying to draw for you. This is suppose extradural hemorrhage. This is brain matter. This is extradural hemorrhage, okay? So what happens? The brain matter get compressed. This is brain. So the extradural hemorrhage, this is the hemorrhage, okay? Extradural. So the brain matter get compressed, okay, by this. Skull is a very protective structure. It is a hard shell, and durameter also very hard. So it is spindle shape. Extradural hemorrhage is spindle shape, and subdural hemorrhage can have many. This is subdural hemorrhage. It can have large area involvement, okay, because it is in the softer part of the skull. So extradural hemorrhage cannot take place. They usually in a small area, they cover spindle shape, and subdural is like these shapes. This is like crescent shape, subdural. So the extradural hemorrhage, it compresses brain acutely. And what happens after this compression? The brain suddenly get malfunctioning. So the patient is walking, talking, then die, then collapse. This is called lucid interval. Okay, there is a hidden period of deterioration. This is called lucid interval. Okay, remember this term, lucid interval. It is related with extradural hemorrhage, and it is very dangerous. Okay, this can contribute to sudden death. That's why we may not know that the child has injury. But subdural hemorrhage, the child will present with headache, blurry vision, and he will complain something. Okay, that's why we can understand there may be some pathology, but in extradura we may not understand. Okay, so this paragraph is important: primary and secondary injury. Now during trauma, head trauma, okay, remember that head trauma, I gave you one mnemonic in our group. That is the head trauma mnemonic: urgent CT scan within 1 hour. After head trauma, there are specific guidelines. If any one of these sign present, you have to do urgent CT scan within 1 hour. What is the time limit? Time limit is within 1 hour. But there are certain signs like vomiting 2 times, like less than 5 centimeter of contusion. Okay, there are certain value, certain measurements, certain criteria. If those criteria are present 2 or more, then we will do urgent CT scan within 1 hour. There are certain criteria like extra in the scalp laceration, or the child is having no injury of respiratory distress or nothing. So in those cases the child, we may not do CT scan, we may observe just. Okay, so remember that this mechanism of injury and the presentation of the patient, this is a guideline, nice guideline. Okay, and we will go with this guideline, and this guideline is present in red book. Remember, we have to follow that guideline, the head injury guideline. It is very important. And as we know that active bleeding within 1 hour, we do CT scan. If you do MRI within 1 hour, what happens? Actually, acute hemorrhage you cannot detect, or you fairly detect by MRI, but CT scan is best in acute hemorrhage. Okay, acute hemorrhage, acute hematoma, we will do CT scan. And remember, MRI needs expertise. MRI needs special precautions, special machine, and MRI cannot be done in a hurry. So CT scan you can do, but MRI is a more sophisticated procedure. Okay, so that's why in acute cases, in acute emergency, usually we don't do MRI. Okay, so these things, CT scan you can do, uh, but MRI we will do in a chronic cases, okay, not acute cases. This diffuse axonal injury, just read one time what is diffuse axonal injury. It is one of the most serious form of primary neuronal injury, in which actually the brain does not get, I mean, there is no such direct injury to the brain, but axons got damaged. Okay, so the patient may have, I mean, deterioration, rapid deterioration, and the signs of the actually axonal damage, like, upper motor neuron signs, there will be signs of neuronal damage. Okay, so nothing from here. So these, remember the pathophysiology of extradura and subdura, okay, and the shape, extradura is spindle shape and subdura is crescentic shape. Remember the shape. And which one has lucid interval? Extradural has lucid interval. Okay, now this is the box, nice guideline of CT scan. Okay, this is the box, very important. Any one of this injury, if any one, and the lower part is more than one, you need more than one. Okay, so remember, this is all we already discussed. What is this indication? You have to remember it by heart, because they sometimes change the number, like Glasgow coma scale 13 or low. Then vomiting is 2 times, not more than two times. Then amnesia for 3 minutes. Okay, amnesia for 3 minutes is not an indication. Okay, amnesia for more than 5 minutes is an indication. So remember these things, huh? And this is the gray matter and white matter axonal shearing. I mean, there may be sometime tearing of the axons that also causes damage and upper motor neuron sign. Okay, I will suggest you do not leave the meeting. Okay, I have to join again and again. This is the trouble. Okay, now what is this page? Okay, we discussed in our last class that subdural hematoma, there is another two possibility: accidental injury, non-accidental injury. Another is one. Another is, who can tell us? Another is
Glutaric aciduria.
yes, glutaric acidemia. So we have two kinds of disease or DD, differential diagnosis. One is non-accidental injury in the small child, and glutaric acidemia in inborn error of metabolism. So the differential diagnosis is, but remember, in an non-accident child, there will be other signs of injury in the body. There will be oval shaped mark in the chest or something, shaken baby syndrome. And in glutaric acidemia, there will be hypoglycemia, there will be metabolic acidosis. We know, we read in our last class, metabolic class. Okay, so yeah, so remember that not only subdural hematoma will help us. Okay, we have to think about other differential diagnosis, other physical findings. Secondary injury we discussed, management we discussed. So outcome, remember that cognitive, behavior and psychiatric problem occur after the any kind of head injury. Okay, cognitive, this is cognitive, then memory, learning problem, language problem, behavior problem, psychiatric problem, personality problem. So head injury during childhood, it is not so much benign, right? It can have large effect. Even the mortality will be increased in later age. These are the chronic effect. Now spinal cord injury. Okay, spinal cord injury is one of the most common. Please read these topics very well. Okay, spinal cord injury. What type of spinal cord injury we know that, like, spinal cord can have spinal shock. What is the features of the spinal shock? Then transection of the spinal cord. If you cut down the spinal cord, what will happen? The level below the cord, will have upper motor neuron sign. Why? At the level, there will be lower motor neuron sign. Okay, why? Because the fibers, pyramidal tract, will carry the signal from the brain, and you will get these fibers cut down. Okay, the neurons, that is called pyramidal tract, it is present in the white matter of the spinal cord, so it will cut down. And the gray matter that cut down in the area section, that gray matter contain lower motor neurons. So this lower motor neuron will cause you the lower motor neuron palsy. So you will find a mixed variety of palsy. Okay. And what is Brown-Sequard syndrome? There is loss of position, vibration, sense, like this. Okay, you have to know why which fiber cut down and what is the type of the lesion. We have a case in our task cases book, that is the for this injury to the spinal cord, and at the level of the lesion, we call it level of lesion. So we will read details in that chapter. Okay, and I will suggest you, please read what is spinal shock, please read what is Brown-Sequard syndrome, and please read transection of the spinal cord. These things will not only give you the idea of the nervous system, but also will guide you toward many clinical problem in your future exams or future life. Okay, and don't ask me question in the chat, because I don't see chats in while I study. Okay, I cannot see chat, that is a problem. Okay, now thoracic injury, abdominal injury. So remember that in children, thoracic injury is more dangerous than the adult. Why? Because their rib cage is soft. So any impact force directly go to the lungs, because it is soft rib cage. What happens to the adult? Adult rib cage is adult's rib cage is strong, so they prevent the force. That's why the breakdown of the rib prevent the lung injury. But in children, rib does not get broken down. They cannot broken down because they are soft, so they transmit the full force to the lung. That's why the lung contusion, these are more common in pediatric patient, small children. Abdominal injury, this type of question in accident will come, like this rupture of the internal organ, like cycle handle. If a patient, a child got injured by the cycle handle in the abdomen, mostly chance is splenic rupture. Okay, so that's why remember that intra-abdominal injury from external force can cause splenic rupture, and the child can rapidly go into shock. Okay, so the only treatment is correction of the shock and laparotomy. You have to stop the bleeding by operation. And liver injury can happen, but liver is protected by some parts by the rib cage. Okay, and yes, liver and spleen both can be injured by cycle handle or road traffic accidents. Okay. Burn and scald is also very important. We know, we already read many points in burn and scald. And remember, in any pediatric accident and emergency, we have to think about non-accidental injury. This is very important. We have to keep in mind. Okay, the severity of burn, contact burn, if it is 6 hours, temperature 44, these things will not directly come in exam, but you can read one time that if the burn is more time, contact burn is more temperature, then less time is required for full burn. Now this question, obviously very important question about burn. See, here they are given the Parkland formula. The first answer of the formula is wrong. It is not 8 hour, okay? It is 4 hours, so it is wrong. And sodium chloride, not a preferred method, so not a preferred fluid. We give Hartmann solution, because Hartmann solution contain electrolytes. Then maintained requirement or addition, yes, maintenance fluid required. So this is the answer. We know that in our any kind of pediatric accident and emergency, we give resuscitation fluid if the baby is dehydrated on shock. Then we correct, after correction of the shock, we give maintenance fluid like DKA, like diarrhea, any kind of pediatric emergency. So here also, after the shock correction, we will give maintenance fluid. So this is the answer. Okay, C. And D and E also very wrong, because urine output is definitely an important monitoring therapy, and volume resuscitation of course required according to the depth of the burn. So what are the types of burn? We already know that there are superficial burn, there are deep burn, and there are full thickness burn. Who can tell us up to which layer burn is painful? Anyone can tell us up to which layer it will be painful, and then after it will be painless?
Partial thickness, ma'am.
Superficial partial thickness.
Yeah, you can say superficial partial thickness. And yeah, okay, yeah, superficial partial thickness, because the nerve endings end here. Okay, and then after that, from which layer the surgery or skin grafting may be required? From which layer the skin grafting will be required in later on in future life? From
Full
deep.
thickness?
Deep partial
Okay.
thickness.
Yeah, deep layer. Yeah.
Deep layer.
Another
Okay.
point, remember, if the burn area is red, it is good or bad? If the burn area you see red, it
Good.
is good, yes, because it has
Good.
contained blood supply. If the burn area is white or yellow color, that means it is deep. So remember, there are some initiating points, some points you can identify that this is superficial burn and this is deep burn. Okay, and deep burn usually end up with skin grafting, and their prognosis is very poor. And poor full thickness burn, there is contracture, so they need release surgery. So this is very bad. Okay, so this is the Parkland formula. If you see this formula, volume of fluid for 24 hours. These things, remember that it needed for 24 hours. So 4 into percentage of body surface area into body weight. Percentage of body surface area, how we calculate? There is two formula, okay, for pediatric and for adult. So see this picture from the Google. This picture is not present here, okay? So see this picture in the Google, that which one is which area. And remember, there are certain area which has more sensitive, like genitalia, face, and the flexural area. Write it down in your book: genitalia, face, and the flexors. These area have high emergency. I mean, if this area has burn, you have to refer to the plastic surgeon, because this area is a high chance the child will be have contracture, loss of facial deformity, so these things. And for every burn we have to think about the non-accidental injury. Just can you tell me that there are certain, we resuscitate by normal saline, right? 20% normal 20 ml per kg normal saline for every shock patient, except few condition, like here in the Parkland formula it is not 20 ml. Okay, after shock correction, the maintenance fluid is calculated by this. Okay, and we do not deduct the maintenance, we did not deduct the Parkland fluid from the shock fluid. I mean, suppose you gave 40 ml of correction of shock fluid. Okay, you cannot minus it from this Parkland 24-hour formula. Okay, so remember that this fluid 24-hour you will give in extra as a maintenance. So there are certain amount of pediatric emergency we do not use 20 ml, like decay. Now the 2020 guideline, yes, we use decay. Previously it was 10 ml per kg. Now we give 20 ml per kg. Okay. Another is cardiogenic shock. In cardiogenic shock, we do not give 20 ml per kg, right? We give 10 ml. We give a small volume, then we give ionotropes. Then suppose a nephrotic syndrome or protein energy malnutrition child, we do not give 20 ml. In nephrotic syndrome, we give 10 ml. Then if not corrected, we give albumin. Same as protein energy malnutrition, same as septic shock. After 40 ml of correction, if the shock is not improved, then we think it may be a case of septic shock, right? We give antibiotic, broad spectrum antibiotic, and ionotrope. So there are certain variation of the shock management, like the scenario I said. Okay, so you have to know this scenario, each and every scenario, like nephrotic syndrome with shock, protein energy malnutrition with shock, cardiogenic shock, then septic shock, DKA, neonatal sepsis with shock. These things you have to know very clearly, okay? And the burn area, this is your homework. You will do this burn area of pediatric, okay? So more than 30% if burn, okay, it is larger burn, it is called larger burn, and there is some release of systemic inflammatory response. And this systemic inflammatory response mediators like cytokine, prostaglandin, histamine, they actually causes capillary leak, and the child goes into shock more rapidly. That's why we give antibiotic, broad spectrum antibiotic in burn. Also, the cause of death may be myocardial ischemia, necrosis of the myocardial cells. Okay, so there are multiple cause of death in burn. Okay. Now next.
Excuse me, ma'am, I have one query.
Yes,
In burns, we will also give 20 ml per kg, right?
yes,
If the
for
patient is
resuscitation. Yes, for
two
resuscitation.
two boluses, and then
Yes.
okay.
Yes, two boluses for shock in everywhere. We read now that we read the two bolus we can give. Then before giving third bolus, we have to contact with the consultant.
Consultant, yes, yes,
Yes.
yes.
And then the consultant will decide whether we will give inotropes or not. And then another problem is that septic shock or cardiogenic shock, or some other causes of shock. So after two boluses we will, and this is Parkland formula for maintenance fluid. This is not for resuscitation fluid, remember. Okay. Dr. Neela messaged, ma'am, I am not in. Dr. Neela, are you here? You joined or not?
I'm in, ma'am. I'm in. Thank you.
Okay, thank you. Okay, I did not check message. Sorry for that. Okay, now let us move. So in general, remember at analgesia, this question came. Okay, this urine output question came in exam. This full 3 question came from here. Number 1 question came that urine output is not important for burn patient. Of course, it is important. Urine output, if less than 1 ml per kg per hour, then there is considering hypovolemia. Then another question came like a burn child who was very toxic looking, he was very in pain, and what is the primary drug you will give? The child is not in shock. Okay, capillary refill time is 2. Now what is the primary drug? Well, there was antibiotic, there was IV morphine, there was subcutaneous morphine, and there was intranasal morphine. So this is our palliative class we will do. So what do you think, a burn child, what type of morphine you will give?
Intranasal.
Intranasal diamorphine. Why? Because the child is in pain and he has already injury to the subcutaneous tissue, and intravenous fluid excess is not possible rapidly. So you will correct the pain. You will reduce the pain by intranasal. Intranasal route is very good, very easy, right? And we read in our last class that any case of scald or burn, what we do? We do 20 minutes of running tap water, room temperature, running tap water, uh, coolness. Now remember, inhalational injury is also very, very important and more dangerous because it can cause lung injury directly, and the after effect of this lung injury will be fibrosis of the esophagus and contracture of the airways. So it is more dangerous. Inhalational injury, you have to maintain there is a possibility of ARDS, and particularly some compound like aldehyde, nitrogen, sulfur, carbon monoxide. This carbon monoxide poisoning is important, remember. They can come in exam. And this carbon monoxide poisoning, what happens? The hemoglobin is replaced
By
by
carbon monoxide.
yes, carbon monoxide. So what happens? SpO2 remains 90% or more, but the child is actually hypoxic. Okay, so the child death rate is high because of the replacement of carbohemoglobin with the oxyhemoglobin. So the SpO2 you cannot measure. You have to do blood gas. Okay, and you will see there is severe hypoxia. And the treatment is hyperbaric oxygen, high flow oxygen we give. So, and this carbon monoxide poisoning is very common after what? After some
Smoke and coal injury.
coal. Suppose someone is smoking at home, there is a fireplace or fire in the home. Okay. Next, this carbon monoxide poisoning, this is the very important. Okay, it is toxic effect and it is 230 times greater affinity than oxygen. This carbon monoxide is 230 times greater affinity than the oxygen. It is important line, huh? Any question until now? Are you getting this poisoning? We are finishing one by one poisoning. Okay. Now, the symptom of carbon monoxide poisoning is important, like flu-like. This, remember this thing, flu-like illness. This question came in exam. the carbon monoxide poisoning. They have flu-like illness, dizziness. Okay. And in hospital setting, carboxy, okay, I already discussed this thing. You have to do blood gas. And treatment is high flow oxygen via a non-breathable mask and hyperbaric oxygen, and you can give, depending on the extent of poisoning, long-term effect. This question came in exam. The long-term effect of carbon monoxide poisoning is hypoxic brain damage. So just like perinatal asphyxia, it is also dangerous for children. Then drowning. Come to drowning. Drowning is another important accident in pediatric. Remember that previously it was near drowning or something, submersion, near drown. Now it is changed. Now there is no near drowning. The terminology is replaced by drowning. All cases, even less than 1 minute, if the child has submersion, the child cannot breathe, the same injury, hypoxic injury to the brain occurs. So drowning, near drowning, saltwater drowning, heavy water drowning, plain water drowning, all are same now. There is no difference in management. Okay, so don't get confused with the management of salt water and plain water. The management is same, but the salt water more chance of development of hypernatremia in the blood. This is one important point, but the management is same. There is multi system involvement, kidney failure, lung failure, temperature instability. So you need active resuscitation of the burned patient, the drowning patient. After removing from the water, what you have to do, you have to remove all the cloth and cover the child with a blanket or a hot surface or a hot area. Then you have to start resuscitation. If the child is unconscious, start with ABC, like we do. Swab the mouth, like external, there can be external particle in the mouth. Swab the mouth, then start breathing. Okay, 5 inflation breath, then we'll start chest compression, like every child. Okay, so nothing, there is nothing. Now the diving reflex, diving reflex means the cold water. Okay, cold water causes bradycardia. We use this reflex in one disease. Okay, who can tell us in which disease we use this diving reflex? We use cold water or we use ice for treatment?
Ma'am, in SVT,
Yes,
vasovagal reflex.
yes. It is called diving reflex.
SBT?
It is a protective mechanism, when we triggered by some contact of cold, then what happens, our heart rate slowly goes down. This is a protective mechanism. Okay, and there is peripheral vasoconstriction, and so we give this as a treatment for supraventricular tachycardia. The type of water, salt water, was once thought to be relevant outcome, but now there is no difference. But if the water is dirty, contaminated with chemicals, then there is further respiratory complication. If it is salty water, then there is a high chance of hypernatremia. But this is the difference. Otherwise, there is no difference. Okay, any question until now? Okay, now next is sudden infant death syndrome. We read this topic yesterday, last class. Sudden infant death syndrome. There is 2 to 4 months. That is the optimum age. Why? Because at this age, our brain centers does not get mature. Okay, that's why we do not encourage to sleep with the same bed or sleep with the sofa. Okay, we know there are certain criteria for sleeping position of the children. So here what we have to read, boys are more common, right? We know boys are more common than the girl for Sudhi. Now this question about sudden infant death syndrome, you see this question that pacifier, we discussed this thing. Which one of the following is not a recognized risk factor? We know that pacifier or dummy, this reduces sudden infant death. They are good after 6 months, not before 6 months. Because before 6 months we do not use dummy or pacifier. After 6 months, if we use dummy, the secretion, the baby will swallow the secretion, so the baby will not have choking attack at sleep, during sleep. Okay, so it is a diagnosis of exclusion. Remember, you cannot diagnose without the investigation or post-mortem report. So the environmental factors we already discussed in our last class. The temperature should be not too low, not too high. The baby will sleep in a separate cot, in a same room, in a separate cot. At the foot end, the baby's foot will touch at the foot end. The covers should not be too big. Okay, it should be baby size. Then there will be no sofa sitting, no sofa sleeping, no overheating. Okay, and breastfeeding reduces sudden infant death. So this is the picture we already saw in our FOP cases book, right? So there are some external factor, internal factor, and developmental age. This is the when these three criteria met, together, this usually contribute to the sudden infant death syndrome. Okay. Maternal age is also a factor, remember, because maternal age is too little age or too high age. Too little age and too high age, both are contraindicated, both are factors for sudden infant death syndrome. Okay. Now, multiple seats in the family. Okay, this is important. That's why to prevent the multiple seats, what we do, we have a CONI program, Care of Next Infant program. And in England and certain other areas, there is Back to Sleep campaign. And this campaign tell us that babies should be slept in their back, not in prone or semi-prone position. And if you have um, in a family, if you have like sudden infant death syndrome, you have to investigate it for as a inborn error or some other disease, genetic disease. Okay, any question until now? We finished our accident. There is also some other accident. What is that? That is called trauma. We read our FOP cases book. Yes.
Excuse me. This
Yes.
SIDS actually doesn't happen in a too high age of mother. Probably it happens only in the low maternal age.
Now, too high age is a contributing factor in that case. They have high chance of congenital anomalies like Down syndromes. Another is like if the family member is a big family like multipara, they have also high chance of sudden infant death syndrome. Multiparity is a factor of sudden infant death.
You mean if the mother's age is like 35, 40, that the baby born is basically having a more prone for the SIDS?
Yeah, because after 40 years, the sudden infant death syndrome, also the congenital anomalies, they are rises actually. Some diseases are related with maternal age. Another important point.
Because the reason is
another important point is the child. The more the age of the mother, the more the big the family, right? Because in our world, the mother start get pregnancy after 25. So if more the age, they have multiparity. Actually, it is related with mainly multiparity. Okay.
Thank you.
Okay. So the poisoning is most important in middle age group. What is the age group? Middle age group. Because this is accidental poisoning. Okay. Most important. Remember this age. And paracetamol poisoning, bleach, we read in our FOP cases book. Bleach poisoning is household poisoning. We encourage milk. For the children. Okay, now next is paracetamol poisoning. We will read detail. There are certain other drugs which is used and present at the family like ibuprofen, these drugs, iron tablet, then oral contraceptive pill. Okay, this you will frequently see oral contraceptive pill poisoning. Okay, because the parent has this tablet at home, and you will frequently see iron tablet poisoning. And also some family uses anti-epileptic, some family has anti-epileptic drug because some child has epilepsy, so you will find that anti-epileptic drug. And if the grandfather or grandmother has hypertension or diabetes, they use the oral hypoglycemic agent like metformin. So you will see these things, and especially the cardiac drugs, like some hypertensive drugs. So these poisoning are very common, household poisoning. And toddlers, like 4 to 5 years, they are the most vulnerable age group because they walk around the home and they find something. And iron tablet is most important for poisoning because iron tablet look like chocolate because it is brown color. So just look like chocolate, and it is sweet. So when the children swallow it, they swallow many tablet together because it is sweet also. So that's why the iron tablet is dangerous because it can cause many hazards like fibrosis, hemorrhage. Okay. Okay, so these that's why in England they use child resistant container. Child resistant means the child cannot open the container, okay, because it is lid is somehow very tight, or lid is in a fashion, it is like and everyone cannot open it. And this is the medication which is has very low therapy, very low মানে dose, toxic dose, মানে fatal dose is near about the toxic dose, like tricyclic antidepressant, anti-malarial, beta blockers, calcium channel blockers, oral hypoglycemia, then antiarrhythmic. Okay, these drugs are at very low dose the children can get toxic effect. So, recognition and evaluation of a poisoned child. Number one, when a child get poisoned, okay, if parents comes to you, parents can complain in two way. Visible poisonous child, I mean the parents will give you a history of poison. Otherwise, the parent will give you no history of poison. There may be two kinds of scenario. One scenario is like accidental poisoning, parent does not know, or it can be non-accidental poisoning, parents does not want to tell you. Okay, and the second scenario, the child will be poisoned, and parents will tell you the exact history that I saw the bottle is empty, I saw the medicine strip is empty, and this is the medicine the child took. I don't know how many she took, because in the bottle how many tablet I don't know, or in the how, because syrup you can measure that one bottle, okay, half bottle he ingested, but tablet in the container you cannot measure how many tablets were there. Okay, so this kind of scenario will come, and sometime you will find some smell like OPC poisoning. You will find OPC poisoning smell, okay, like kerosene poisoning, you will find the smell. Sometime in the medicine case like paracetamol or like these things, you will not find any smell. Okay, so there are two kind of history. Any child who is unconscious, whether it is a teenager or whether it is a small child, okay, we know that in case of neonate, any collapsed neonate, we will think about sepsis. But in case of children like infant or toddler or teenager, any kind of unconscious child, we will think about toxic substance. Remember, this is okay. So what is the toxicity when there is any child? Is it accidental or non-accidental or suicidal, deliberate self-harm? Okay, we have to think about this issue, and we have to, after resuscitation, we have to ask the friends, relatives, the witness who bring the child. Okay, then we have to think about this thing, toxicity, the co-ingested, if any child took alcohol with aspirin or alcohol with MDMA, the toxicity increased. Toxicity increase because they have okay. So in a minority cases, like, so these things you have to keep in mind, okay, that toxicity of the substance. Then you have to keep in mind that co-ingested substance like alcohol, paracetamol and aspirin, okay, and dose and history and symptom present, time, what is the time of ingestion, and other comorbidity, like the child may have CP or may have diabetes or may have hypertension. So these things you have to keep in mind during managing a child. Okay, and illicit drug like cocaine, marijuana, and like um, MDMA, ecstasy, alcohol, okay, pethidine, heroin, these things. And now the drug that is called Viagra, Adegra, these are all toxic. These are all toxic and illicit type of drug, and these are all together are called toxidrome. Okay, any kind of poisoning we read in our last class, any kind of poisoning within 24 hours, where we will refer the child? Who will see the child next after management?
Psychiatrist.
Psychiatrist, yes, within 24 hours.
Psychiatrist.
Yes, what is that called? That is called CAMS, right? Child and Adolescent Mental Health Service. Now, this picture is very, very important. Give it star mark, please. This picture, like classic toxidrome syndrome. Okay, toxidrome means the symptom and the management. Anticholinergic drug. Here I have some mnemonic. I have some mnemonic here in this topic, like hallucinating drug and sympathomimetic drug. You see here hallucination and sympathomimetic. You see hallucination and sympathomimetic, they are same. You see this thing, they are same. Amphetamine, cocaine, MDMA, these are hallucinating drug. And cocaine, MDMA and amphetamine, same drug. So this same drug effect also same. They causes hallucination, panic attack, hypertension, tachycardia, tachypnea. Same here, tachypnea, hypertension, mydriasis, agitation, seizure, hyperthermia, diaphoresis. So diaphoresis means sweating, right? Sweating, mydriasis, tachycardia, tachypnea, hypertension, seizure. These drugs are hallucinogenic drug and also sympathomimetic, mane agonist. Mimetic mane agonist. Lytic mane antagonist, right? So remember, these are same. Then some drugs are reverse, like anticholinergic drug and cholinergic drug. Their effect are totally reversed. You see, anticholinergic mane antagonist, cholinergic mane agonist. So so we know the dry like blind like bat, dry like rat. What is that mnemonic? Okay, so anticholinergic effect will be dryness, like there will be mydriasis, blind like bat. There will be urinary retention. There will be hyperthermia, warm and dry skin. Okay, tachycardia. This is anticholinergic drugs. Anticholinergic drugs. Okay, and cholinergic drugs like organophosphorus. Anticholinergic drug are which type of drug? Atropine. And cholinergic drug are which type of drug? OPC, organophosphorus poisoning. So remember, there atropine is the antidote of OPC poisoning. Okay, OPC is cholinergic drug and atropine is anticholinergic drug. Also, and tricyclic antidepressant, carbamazepine, phenothiazine, these drugs have same effect as atropine. Okay, so remember these drugs side effect and the antidote. So cholinergic drug is OPC poisoning, very dangerous. And mushroom, this question came in exam, mushroom. Okay, some mushrooms are poisonous, toxic. If you eat those mushroom, okay, there will be like this effect, like cholinergic effect. There will be, everything there is water, salivation, lacrimation, urination, diarrhea, bronchoria, then bradycardia, vomiting, everywhere there is watery. So remember, anticholinergic drug is dry, cholinergic drug is wet. These are reverse, okay? Now, opioid is morphine, codeine, pethidine, methadone. They are opioid. Their class is opioid. Same mechanism of action: hypoventilation, hypotension. Except cocaine. Cocaine is not opioid. Cocaine is sympathomimetic drug, because we read in cocaine poisoning. What is the antidote of cocaine? Who can tell us? What is the antidote of cocaine?
Lorazepam.
Yes.
I feel lorazepam.
IV lorazepam. Very good. Lorazepam. Yes. Now, so these drugs, opioid actually slow the body. See, hypoventilation, hypotension, meiosis, sedation. They actually like death. Opioid causes death. So they are like a dead child. And sedative hypnotic also like death. In addition, they causes ataxia. This question came in exam, like phenobarbital poisoning. Benzodiazepine poisoning causes ataxia, blurry vision, hallucination, slurring of the speech, and nystagmus. These two features, they gave nystagmus and ataxia. So this is important or not? This classic toxidrome, very, very important. Whenever you read these drugs, you have to know the class and the common drugs and mechanism of action and the antidote. Okay, so there are certain drugs which has high anion gap, like aspirin. We know mud pile. Okay, there is ethanol poisoning, methanol poisoning, aspirin poisoning, iron poisoning. They have high anion gap. okay, because they create some anions in the body. So remember this high anion gap, mud pile mnemonic. This is the mud pile mnemonic. Okay, metabolic acidosis with high anion gap. There is methanol, propylene glycol, iron, isoniazide, ethylene glycol, salicylate mane aspirin. Also uremia, diabetic ketoacidosis, lactic ketoacidosis, cyanide poisoning. These are all high anion gap metabolic acidosis. Okay, now next. So the uh, management of, we will read now in our green book of pediatrics guideline, that is the management, how we will do management, some extra points we will read. Remember, any child who is coming with poison, you have to remove the clothes and you have to cover with another clothes, because clothing also help in absorption. Okay, and vomitus will create some media for culture media for growth of bacteria, so you have to remove the clothes. Activated charcoal, very important, give it star mark. Okay, activated charcoal, how many time we can use, every line is important. How many this is actually carbon substance that has some pore, and this pore actually absorb some poison. They have oxidizing atmosphere, so they are highly porous particle. So this particle actually absorb the poison. That's why we give activated charcoal in carbon form. And this activated charcoal we give by either juice or some drinking water. So they can either directly swallow or nasogastric tube via the nasogastric tube. Okay, so this charcoal is given in a powder form. And we usually we give within 1 hour before, because after 1 hour there is no poison in the stomach, usually everything is absorbed. So to allow this activated charcoal, we disperse it in water, then we give within 1 hour. Okay, after 1 hour actually there is a reduction of absorption. তারপর এখানে this is very important, that which type of poisoning we will give charcoal and which type we will not give. No contraindication of activated charcoal, like administration of activated charcoal should be considered when all of the following criteria are met. If there is gastrointestinal obstruction, then you cannot give charcoal. Okay, and if the airway is not protected, you cannot give charcoal, because the child will aspirate. Okay, these things like iron, lithium, potassium, alcohol, pesticides are the main substance that are not effectively absorbed by the activated charcoal. So remember, they are, if there is iron poisoning, lithium poisoning, potassium salt poisoning, or alcohol and pesticide poisoning, and the option is activated charcoal within 1 hour. No, this is wrong answer, because they will not work. Okay, so this question is important. Another is, some drug has small volume of distribution and prolonged elimination half-life. So some drug has prolonged elimination, that's why we give multiple times. So this question came in exam, that multiple time we can use charcoal or not. Yes, we can use multiple time. Okay, next. Some drugs like carbamazepine, dapsone, phenobarbital, quinine, they are enhanced by using multiple dose of activated charcoal. These drugs have high volume of distribution. Okay, dapsone, high volume of distribution and prolonged time of distribution. So you will use multiple time charcoal, these drugs. So they are very important. Next, example of antidote. Give it star mark. It is also very important. Example of antidote. Like we know, paracetamol poisoning, antidote is N-acetylcysteine. This mechanism of action will come in exam. What is the mode of action of N-acetylcysteine? It actually create glutathione. Okay, this glutathione actually bind with toxic NAPKI, that is a toxic product of paracetamol poisoning. And iron, it is bind with the free iron and chelation. Okay, and causes renal elimination. Remember, exactly same line will not come. They will twist it, like help in removing from the by urine, like this. They will twist something. And opioid competitive antagonist of the receptor. It directly does not eliminate. Naloxone does not eliminate. Okay, and fomepizole also competitive blocker. This question came in exam. Why we use ethanol in case of ethylene glycol poisoning? Because it is competitive inhibitor of the enzyme that is dehydrogenase, alcohol dehydrogenase. So you have to read everything. Warfarin is vitamin K, benzodiazepine, flumazenil. Most of them are competitive blocker. Okay, most of them are receptor blocker. This question came in exam. Organophosphorus is pralidoxim. Okay, and like this. Now, gastric lavage we don't usually do. Remember, we don't do usually because they have chance of aspiration. So it is now rarely used. Okay, we don't use nowadays. Another one, write it down, that we do not give gastric lavage in case of acid, alkali, and then kerosene and volatile substance. Okay, acid, alkali, kerosene, and volatile. We don't give gastric lavage because they will cause aspiration pneumonia, scarring of the esophagus and trachea. Whole bowel irrigation, induced vomiting, they are all contraindicated now. Okay, they are now not used in our pediatric age group. Maybe they are used in adult, but we cannot use it. Next, what is the role of urinary alkalinization? Anyone can tell us why we use urine alkali, sodium bicarbonate, and which kind of poisoning we use?
This is used in aspirin poison, salicylates.
Salicylate poisoning, yeah, because it is
we wanted to basically force diuresis. We want to maintain the pH somewhere close to 7 or 8.
Yes, yes.
Because the half-life of aspirin otherwise is very short, it's 4 to 6 hours. But once actually the poisoning, the half-life becomes longer, like maybe 16 hours, maybe 20 hours. So we want to eliminate drug. The drug is basically eliminated by the alkalinization, the soda bicarb.
Yeah, we
only
give
by the forced diuresis.
Yeah, we give usually sodium bicarb. Okay, sodium bicarb to enhance the excretion of drug, because these drugs are usually acidic. Salicylate, phenobarbital, methotrexate, chemotherapeutic. These are the acidic drugs. Okay, these are the drugs, and salicylate is the main drug. We will use sodium bicarb because we know that aspirin is a over-the-counter drug. It is present in almost every home. Okay, then chance of poisoning is more. So we use urinary alkalinization. Now, intravenous lipid. There is another formula. We give lipid, IV lipid, because lipid absorbs the drug. It prevents the toxic effect. Okay. Some lipid soluble drug. Some drugs are lipid soluble. They are like in overdose of lipid soluble drug. We use this thing, such as beta blocker, calcium channel blocker, antihypertensive drugs. Okay. Now, next. Antidotes we already read. Poisoning prevention, how we do poisoning prevention. Number one is keep all the medicine medicine away from child and away from a safer, cooler place, like above the shelf, like this. And lead, child protective lead. Okay, this is everything important. And supervision, of course, supervision. Now, paracetamol poisoning comes to our main topic today, that is paracetamol, aspirin. This kind of poisoning is very important. So paracetamol poisoning, this question is a 14-year-old girl who reported has been overdose of paracetamol. There are certain rules in paracetamol poisoning, remember. Like, what is the dose? What is the dose of the paracetamol poisoning? Number one. How many hours have passed? Number two. Is it staggering dose? What do you mean by staggering dose? Can anyone tell us? What do you mean by staggered dose?
Taken within 1 hour.
Within?
1 hour.
Can you raise your voice? I cannot hear you.
Sorry, I think it's taken within 1 hour.
No. Staggering dose is not 1 hour. Okay, anyone?
24 hours.
Not actually hours. Staggering dose means, small dose for long time. The patient does not know how many tablets he ingested or she ingested. This is called staggering dose. Staggering এর বাংলা হচ্ছে ছ্যাঁচড়ানো. Okay, like dragging something. You are you are taking 2 tablets now, then after 1 hour 4 tablets, then after 2 hours 2 tablets, like this. This is called staggered dose. Patient does not know how many tablets she or he took. These doses are very dangerous. As soon as the patient comes to us, within 24 hours, you have to start N-acetylcysteine. Okay, because there is no time. There is no time, and patient does not know how many time has passed. So you'll send the blood for N-acetyl. You will send the blood for paracetamol poisoning and start N-acetylcysteine. This is the formula. Okay, this is the criteria. So about the paracetamol poisoning here, which statement is correct? They say the correct statement is toxicity occurs because of saturation of the glutathione mediated inactivation of the toxic metabolite. Yes, glutathione, they actually absorb the NAPK. We know when we take paracetamol, our liver produces glutathione, and they actually absorb the toxic product. But when we take toxic dose, like more doses, then this glutathione are finished. All glutathione is saturated. So the rest of the NAPK, they are free, and they causes injury to the liver. Mainly they causes injury to the liver, and then kidney, and then brain. So treatment with N-acetylcysteine should not be started until result came. No, there are certain exceptions when we can start N-acetylcysteine without serum measurement. Toxic metabolite N-acetylcysteine benzoquinine is produced by glucuronidation. No, glucuronidation is not produced this one. Okay, and serum concentration should be measured within 4 hours. No, usually after 4 hours. For maximum effect, treatment with N-acetylcysteine must be started within 4 hours. No, we can wait. If the dose is not toxic, we can wait up to 4 hours. Okay, this is wrong. So this is the main pathway of paracetamol poisoning. You have to know this pathway. Very, very important pathway. That is the sulfation pathway, glucuronidation pathway, and hydroxylation pathway. This hydroxylation pathway produces NAPK. Okay, give it a star mark. This is hydroxylation pathway. Okay, sulfation pathway is the activated pathway for neonate or infant. Glucuronidation, main pathway for children and adult, and they produces maximum paracetamol metabolism, about 90%, and this pathway only 10%. But when the child take toxic doses, then this is the main culprit for liver injury. And if you give N-acetylcysteine, there will be conjugation and production of the cysteine and markaptopuric acid. Give it star mark. They are non-toxic. So if you give N-acetylcysteine, there will be production of cysteine and markaptopuric acid. That is conjugated form, and they are non-toxic. They will eliminate by the kidney. Okay, any question until now?
So ma'am, will you repeat this one again, the last paragraph? That one.
Yes. This chart.
Yes.
See,
yes.
Maximum metabolism occur by the sulfation and glucuronidation, but some mechanism are done by the hydroxylation, and that produces NAPK. So when there is a toxic dose ingestion, this NAPK causes liver damage. So we give N-acetylcysteine here. It causes conjugation to glutathione, and then they produce cysteine and markaptopuric acid. They are non-toxic. This is the action. Okay, this is the action when we give N-acetylcysteine. Okay.
Okay, ma'am. Thank you, ma'am.
Excuse me, ma'am.
Yes.
Excuse me. When this metabolism in the newborn is done by the sulfation, and which is basically having a non-toxic, why not to give in a newborn like a paracetamol?
You can give, but sulfation mechanism is very minimum mechanism. Glucuronidation mechanism is the maximum mechanism, and glucuronidation is not active. That's why. Sulfation metabolizes very minimum amount of paracetamol. Okay. Okay, next, case history. Case history, this is a child, 14 years, he took 16 paracetamol tablet. So what is the toxic dose of paracetamol, guys? Who can tell us what is the toxic dose of paracetamol? 16 tablets.
200
milligram per kg.
200 or 250?
200
Then
milligram per kg.
200. Okay. So 200 milligram per kg is the toxic. Yes, 200 milligram per kg is the toxic. Here he took more than 200. Okay, because he took almost 8 gram. 8 gram. Okay, 200 milligram per kg. So for a 30 kg child, suppose 6 gram is toxic. Here he took 8 gram. So 8 gram tablet definitely toxic, and the liver enzyme is very high. Prothrombin time was very high. So paracetamol concentration undetectable. See, when the child got toxic dose, we do not wait. We start an acetylcysteine because the level may be non-detectable in serum. Okay, so we'll start immediately an acetylcysteine in view of evidence of hepatotoxicity due to paracetamol. Regular blood test monitoring demonstrate gradual normalization of her prothrombin time. So in this child, even though the paracetamol was not detected in her blood, in his blood or her blood, we gave an acetylcysteine. So this question came many times, that paracetamol was undetectable. What should you do? Of course, the liver function is impaired. You have to start an acetylcysteine. Okay.
And there was a question.
Yeah.
I mean, young girl came in the hospital with taking almost same number of tablets, 12 or 14 year, and she left the hospital. She left the hospital without treatment. What to do?
Yes, we'll call the police.
Okay. Thank you, ma'am.
Next, this is a very important, okay, classically paracetamol toxicity. Since staggering dose, a single dose over 200 milligram per kg is considered to have toxicity, but lower single dose can result in significant problem, such as multiple smaller dose, which is called cumulative dose. Okay, so if any child having staggered dose or cumulative dose, this is also an indication of starting of N-acetylcysteine. So paracetamol poisoning has 3 stages. Give it star mark. First stage, the child has only nausea, vomiting stage, nothing more. Then start with abdominal pain, mane liver toxicity or renal toxicity. Then there is necrosis stage after 3 days, or liver failure, renal failure, cerebral edema and death. This question came in my AKP. Okay, this question, what are the stages? Which stage causes which one, like this? Cerebral edema and death. Okay. So you are not only reading for part 1, okay? Remember, you are reading for AKP2, AKPN also. So biochemical evidence, this whole paragraph is important. Biochemical evidence of paracetamol poisoning and liver injury. These are very important. Like here they described what I already described. Okay, the NAPKI, what is the N-acetyl P-benzoquinine amine. This is very toxic, and we neutralize it by giving N-acetylcysteine. So N-acetylcysteine within 8 hours of ingestion helps to limit hepatotoxicity. Give it star mark here. It is important. Within 8 hours is the best if we give. It produces glutathione reserve. Okay, thus enhance the elimination of the N-acetylcysteine. Now this is very important, that measurement of the plasma paracetamol, we should wait at least 4 hours. Okay, and there is a nomogram of paracetamol poisoning. We will read it today. What is the nomogram? And certain factors which are as greater risk, give it star mark. If any child is taking phenytoin or carbamazepine, that is called hepatic enzyme inducers, or neonate who has the main pathway for sulfation, who does not have glucuronidation pathway, so they have high chance of toxicity. And if the child is malnourished, okay, these things are contributing factor. Also, if the child take paracetamol and aspirin together, also if the child take paracetamol and alcohol together, these are very dangerous. So liver transplantation is very urgent treatment, and in UK there is a high chance of high number of liver transplant occur after paracetamol poisoning. And poor prognostic factor, this is also important. If the pH is very low, and if there is INR high and creatinine high, and there is encephalopathy, the child will die. Actually, prognosis poor. And this is the hepatocellular necrosis. It is the more common cause of death in paracetamol poisoning. So we can give N-acetylcysteine to prevent this. Another drug is, methionine. Write it down. Methionine oral we can give. Okay, if any child does not want IV N-acetylcysteine, you can give methionine oral. But methionine oral we cannot give in unconscious child or the child who has hepatic necrosis. We have to give N-acetylcysteine. But if any child does not want a stable child, we can give methionine oral. This question came in exam. Okay, methionine oral, same effect. Methionine also produces glutathione. And this poisoning, this is aspirin poisoning. Okay, 13-year-old, see the scenario. He presented with dizziness and there was confusion, blood gas, there was high anion gap metabolic acidosis, and his mother find there was aspirin bottle of her sons. Okay, so the case scenario is about aspirin because aspirin causes high anion gap metabolic acidosis. Paracetamol will not cause high anion gap metabolic acidosis. So this is a very dangerous drug and common drug. Toxic dose is 150. So 200 is paracetamol and 150 is aspirin. Okay. And what is the main action here? Well, the cause of death. The cause of death are many. Like there is kidney, renal failure, liver, also liver toxicity, renal failure. Okay, that's why we do dialysis. This is an acidic drug. It causes metabolic derangement. Severe metabolic acidosis causes breathing difficulty, hyperventilation. Okay, so if the concentration is 3 to 300, they are therapeutic dose, and greater than 700, they are overdose. So concentration you will measure after 4 hours of ingestion. Okay, and okay, so there are features of respiratory alkalosis in children, but in small children, remember, this respiratory alkalosis may not be present. Why this respiratory alkalosis occur? Because it stimulates the respiratory center, and that's why it causes hyperventilation. So all the carbon dioxide there is wash out and creates respiratory alkalosis. Okay, then with the compensation, there is metabolic acidosis. But in children, they can directly go into metabolic acidosis. And there is production of lactic acid. Okay, this takes time. Actually, this takes 12 to 14 hour time, but in infant it is 4 to 6 hour directly. And the hemodialysis is the treatment, and you can use extra sodium bicarb urinary alkalinization, which will remove extra acetylcysteine, which will remove the salicylate. Okay, nothing much here important. See, this line is important here, one line, that this clearance is depend actually on the urinary pH, not the flow. Okay, so you will not give forced diuresis, you will not give what is that called, you will not give furosemide. Remember, we don't want to remove the poison early, we want to maintain the pH higher so that the acidic drug removes. Okay, so remember, forced diuresis is not required. That means we will not give furosemide. This question came in exam. Okay, that what is the best treatment for aspirin poisoning? There was furosemide, there was IV mannitol, there was IV sodium bicarb, like this. Now, ethylene glycol and other poisoning, they are very rare, but you have to know that what are the sign symptom. Ethylene glycol or alcohol poisoning is of course important. So this 3-year-old boy, he is intoxicated, treated with fomepizole. Okay, this is also treatment, antidote. Now, ethylene glycol, it is a odorless, sweet tasting liquid. Okay, so if you eat, if someone is toxic with this, there is some stage. Okay, then there will be high anion gap metabolic acidosis. See, this is the pathway. Alcohol aldehyde dehydrogenase, this enzyme helps in the toxic effect. Okay, so we give anti-aldehyde dehydrogenase, which is competitive inhibitor. We give ethanol, it is a competitive inhibitor. Okay, now next. This question came in exam, okay? There was fomepizole in the option. Fomepizole is another option for alcohol dehydrogenase. Fomepizole and ethanol, both are option, okay? Remember this fomepizole. This is task question, fomepizole. Now next is iron. So okay, this question also came another. Fomepizole has a significant advantage over the ethanol. What is that? It does not cause intoxication, and it does not cause more poisoning, and it does not cause hypoglycemia. This is important line. So fomepizole is better, but fomepizole is costly. That's why we do not use. We don't have actually. Okay. Now iron poisoning, I already told you, iron poisoning is common because of its color. So serum iron also we will measure after 4 hours, and the measure there is a value. We have to know the value, and any poisoning, remember you have to observe the child for 24 hours, and you have to refer the child to the camps, and then after 4 hours we will measure again, okay, and then so in general, toxic effect is shown when the ingestion of 10 to 20 milligram per kg tablet with severe effect and potentially death. When a fatal dose is 50 to 60 milligram per kg. So this is the toxic dose and fatal dose. These doses of iron, alcohol, they may not come in exam, but the sign symptom are important. Okay. So these things, initial symptom are like hematemesis, diarrhea, abdominal pain, and then there is high anion gap metabolic acidosis, there is multi-organ failure, okay, and then they have stricture formation, okay. This is the late complication of stricture. Primary complication is hemorrhage. Then we measure the serum iron. Then if serum iron is less than 60, okay, then we will give significant poisoning is very unlikely, okay. So remember this point that if less than 60 micromole, then toxicity is very less likely. So remember, we already discussed iron is not absorbed by activated charcoal, so don't give. And irrigation also we don't recommend, okay. And desferrioxamine is the treatment because it binds and causes chelation. Treatment should not be delayed. Treatment should be continued until the acidosis reverse and patient is asymptomatic. Then this question, this is called which type of question? EMQ. This EMQ is a very important EMQ about poisoning, and this type of question you will see in your TAS exam. Okay. So the first question was 3-year-old boy who you see there is sweaty, tachycardia, vomited, drowsy, and increased work of breathing. You see there is tachycardia, tachypnea, sweaty, and the child is playing in the field. So what poisoning causes this kind of feature in the field?
Organophosphorus, ma'am.
Yes, very good. Organophosphorus. The antidote of this one, organophosphorus, we already discussed. Antidote,
Atropine.
Bralidoxy.
yes.
Bralidoxy.
Yes. Pralidoxim also. Yeah, pralidoxim also we can give. And next question is 2-year-old who has found unconscious and respiratory rate is very low and meiosis. So what kind of poisoning? Death-like condition, meiosis, respiratory depression. What kind of poisoning?
Cocaine.
Opiate, not cocaine. Cocaine is reverse. Cocaine causes hypertension. This is hypotension, bradycardia. This is opioid, methadone, pethidine, morphine. This is opioid poisoning, methadone poisoning. Okay. And 14-year-old who is presented with night out. So night out club. He gone on club and then collapse.
MDMA.
Yes.
Cocaine or
Tachypnea, tachycardia. So cocaine or MDMA. Yes.
MDMA.
Yeah, that is ecstasy. MDMA's another name is ecstasy. 3,4 methylene dioxy N methylene amphetamine. This is a group of amphetamine drug. Okay, methamphetamine, amphetamine. They are mood enhancer, party drugs. Okay. Now, since 2008, there is increasing line of lead poisoning. Remember, lead poisoning, old house. Okay, there is lead poisoning in old house. Like, some pipe, they contain lead, and old house contain lead. and lead containing utensil like kasha, shisha, kasha, like this. So lead utensil, lead old home, they contain lead, and this lead are contaminated with groundwater sometime, and that's why the children have high chance of lead poisoning. And this lead poisoning causes acute effect and chronic effect. Chronic effect are what? Chronic effect like developmental delay, cognitive impairment, learning disability. Okay, and one important complication of lead. What you can tell regarding blood? What is that in the blood?
Anemia. Anemia.
Anemia. Yes, unexplained anemia. Unexplained
Basophil
basophilic stippling. Yes, basophilic stippling.
A B C
Yes,
D E.
basophilic stippling you can
Yeah.
see in the lead poisoning. This is just like this one. Suppose this is basophil, and there is, in the wall there is stippling, basophilic stippling, and this is seen in iron. Sorry, this is seen in lead and arsenic, heavy metal poisoning. Lead, arsenic, these are heavy metal. Okay, this is basophilic stippling. So remember, any child with unexplained behavioral issue, behavior problem, cognitive delay, no reason you find anemia, you don't find any reason, think about lead poisoning. Okay, this chart is important. Concentration effect of relationship with lead. So lead can cause skin and muscle lead distribution in the body. Okay, this is important. Lead distribution. Hematological, there is problem in the enzyme inhibition, so they causes poisoning. And yeah, and neurological effect, renal effect. Okay, lead can cause renal effect, interstitial nephritis. Okay, it can cause interstitial nephritis, amino aciduria. Chelating agent like EDATA, ethylene diamine tetraacetate, and DMSA, and 2,3-dimercaptosuccinic acid. These are the treatment for lead poisoning. Okay, fine. Any question? Now we will stop our live. Any question from now here?
Excuse me, ma'am.